Good morning. My name is Janice Siegenhagel, and I'm going to be presenting this webinar this morning, Leading Change in a Pandemic. My husband and I have been married for 21 years. I have a 14-year-old son, and we also have a Boston Terrier dog. His name is actually D-O-G, which does spell dog, and we just call him by his letters. Currently, we live in Victoria on Vancouver Island, and my family often teases me for nerding out when it comes to my work. Just this last year in grade 8, my son learned about microscopes, and I was very enthusiastic in showing him the different microscopes that I have worked with. I've been a technologist for as long as I've been married, so 21 years this year. In Canada, the MedLab technology program includes anatomic pathology, and so from the moment I was in school, I fell in love with pathology. There really was no other area I wanted to work in. I love every aspect of pathology, from grossing, embedding, cutting, staining, immunohistochemistry. I've heard it said that AP can be boring and monotonous, but when you consider the art of what we do, I think it's nothing short of amazing. In my 21 years, I've worked in 3 different health authorities and 5 different hospitals, and it was in one of these hospitals that my coworkers picked up on my nickname, which you would have seen my picture alongside me. There was a picture of the rapper Jay-Z that quickly became my nickname. Yes, it is technically just my initials, but in that lab, we already had one of the techs. His nickname was Snoop Dogg, and so we quickly became more of a nickname than just my initials. Currently, my role is that of technical coordinator for Island Health. I oversee 4 different sites, which means my days include a lot of troubleshooting, policy and procedures, meetings, but my first love has always been the bench work. Even now, as I work behind the desk most days, the patient is still the person I write policies and procedures for, because those directly affect their specimen. Even as we talk about change today, the changes we talk about, we implement, we dream about, they ultimately affect the patient, their experience with us, their report, their diagnosis, and that's why I come to work for them. As I said, I live in Victoria on Vancouver Island. Vancouver Island is situated on the Pacific Ocean off the coast of Canada, and is part of the province of British Columbia. Vancouver Island has an area of 12,407 square meters, so it's not huge, but its land mass is equal to that of Taiwan, and it is larger than Vermont or Rhode Island. Some of the economic sectors are fishing, forestry, agriculture, education, tourism, arts, and healthcare. Fun facts for Vancouver Island: movies like X-Men, Sonic the Hedgehog, Planet of the Apes all used Vancouver Island as their backdrop. Also, TV shows like See and Alone were filmed on location. Also, Pamela Anderson hails from Ladysmith, which is on Vancouver Island as well. Island Health is the health authority that oversees the patients for Vancouver Island. It is broken down into 4 geographies. I oversee 4 sites within this area. However, each geography contains many clinics, physicians, community hospitals that provide specimens to the 4 sites. Powell River, which is technically part of the mainland, is also included in Island Health, and so we process their specimens as well. Because I will talk about them in the presentation, the sites I oversee by name are Royal Jubilee, Nanaimo General, Comox Valley Hospital, and Campbell River Hospital. Campbell River Hospital is a unique site. Their AP department supports the pathologists, frozen sections, and grossing. However, the processing, embedding, and cutting functions are performed by another site, and the slides are shipped back to the hospital. This is a recent clip of the staff shortages, and really something that's been on the radar since 2010. But COVID seems to have exacerbated the effects of it, not only with lab techs, but also with lab assistants. When I interviewed for this position in January of 2019, they asked all the applicants to prepare a presentation on what they saw as the issues facing the department and what were some strategies to combat these issues. So, of course, staff shortages, increased workload, increased turnaround time, backlogs, processor capacity, other aging equipment, patient and physician complaints over reporting times. These are all the things that we were facing as a department, and I then had to discover some strategies to identify some ways that we could quickly impact the problems that we were facing, but with little to no budgetary impact, so that we could buy some big changes in the long run. So the impact of this to Island Health were, like, this slide shows just the increased workload that we were seeing back in 2019. At that time, we were grossing day in and day out and just never catching up. There was more work coming in than we could get done in a day, with new clinics opening up all the time, specifically a skin clinic that dramatically raised the workload in skin specimens. Large OR specimens were lying in the hallway, and along with that, with the increase in specimens was also the complexity of the specimens, which was increasing as well. The amount of blocks coming out of the grossing room was overwhelming, and often racks sat unprocessed as there was a lack in processor capacity. And then there were the slides. The protocols for cutting sections meant that we were creating so many slides for the pathologists to read. And in the last 3 years, we'd seen the number of specimens coming through the 4 site just steadily increase. So in 2017, we had 108,000 cases, in 2018, 112,000 cases, and in 2019, 118,000 cases. So the workload was just steadily increasing. Our immediate action plan. So we head back to my interview. I was hired in January of 2019, and by February, we sat down with the presentation from my interview, and the question was, how can we achieve some of these strategies? At the table at the time was the medical lead of the pathology department, the chief technologist for the World Jubilee site, and we just began discussions of, like, how we submit specimens. Can we reduce the number of blocks created in the gross room and still obtain the necessary diagnostic information? Could we reduce the number of sections that we were cutting at microtomy, or change the way that we cut sections and levels so that pathologists were still getting the diagnostic information that they need, but seeing less glass? Could we change our reflexive testing so we weren't producing slides unnecessarily? Essentially, we just put everything on the table and asked, what can we do differently? The ideas that seemed to make the most sense were then taken to the different groups, pathologists, grossers, embedders, and cutters for their input as well. And then we implemented trials of each idea so that we could see how they would impact workflow, what would the obstacles be that might come up or that we might face. One such would be the changes of sectioning in microtomy. We actually had to train techs to double ribbon because that was something that they had never done before. So it was a long process. Months and months of work went into this. So as you can see, months and months of work went into this. We had to find some quick wins. The fastest win that needed the least amount of input was how to change how we submitted work. So we started by increasing the amount of tissue that we submitted in each block. So for skin biopsies and resections, we went from submitting only 2 sections to 4 sections per block. For GI biopsies, we increased those from 4 pieces to 5 pieces. And then the same for gynae and GU and small biopsies. We increased those to 5 pieces as well. Then we looked at our reflex ordering of levels and IHC. And so the first to change was the breast and whole node ordering. We changed that from 5 slides to just 1 slide. Secondly, and the reason I mentioned the Campbell River site before was Royal Jubilee was the site that had been processing and embedding that work, and so we relocated that work to Nanaimo. That was a project that went live in October of 2019, but actually started back in February as we just worked through what we would need to do to support that relocation of work. We updated our exempt tissue list in May of 2019. We finally implemented the double ribboning after some months of trialing and teaching. And then in November of 2019, we started a departmental review. It's funny that I talk about these as being immediate actions because it was almost a year of work that went into this. But you can see that even just from this slide, the amount of cases increased in column 2 there from 2018 to 2019, but the amount of blocks and slides that we put through decreased. So that was a big win when we consider the workload was increasing, but we were putting through less blocks and slides, which was great for the department and the pathologists. Nothing in pathology is immediate, but it was a bolster to see that our actions had made a big difference over the year, and we did end 2019 without a backlog. We still felt that there was more that could be done, and we wanted to focus on how the work was moving through the department. So this led to a formal review of the department. We conducted 2 reviews simultaneously, one in-house led by myself and another coworker, and the second led by Somagen Diagnostics. We invited James Tang and Anda Wolf. We felt that there needed to be a second set of eyes to show that the in-house review is not biased or skewed by the results or outcome that I wanted. So James and Anne joined us in January of 2020, which would turn out to be the beginning of the pandemic for North America. So our in-house assessment began in 2019 in November, and the department was nervous. Already there'd been enormous change for them in the last 11 months, and here we were, myself and the operations support liaison, saying more change needed to happen. We met for a month beforehand with the unit coordinator to discuss what we were going to look at and how we were going to conduct the review. And I do remember at one point my medical lead just telling me to tread gently as we started this review process. The ultimate goal for the assessment was not to be punitive in any manner, but to just see how the specimens were flowing through the department, to identify any bottlenecks, areas for improvement, and then to work together to find solutions. So we started at the beginning. From the moment the specimen arrived at the door of the department, what happened. And then we really wanted to know from the staff themselves what they felt were obstacles to them doing their jobs. We invited Somagen as a third party to this so that we could essentially, at the end of the day, compare notes. Did we find the same obstacles? Did Somagen see things that we had missed? Did staff feel free to identify the same issues with Somagen as with us? Essentially, we put ourselves under the microscope. So some of the observations from the in-house assessment were we had quite a few vacant shifts and no casual pool. So that was, we considered posting positions. The other thing we noticed was staff utilization. We needed to bring some consistency into the shifts, like the start times, the break times, and aligning our staffing with the workload requirements. So when the bulk of the workload came out, what did our staffing allotment look like at that time? Performance, we needed to document staff performance better and discover a way to track productivity within the department. As well, we found out that we needed to review the training rubric. So we needed to define the expectations of our training documents, review the training documents, and determine if staff were able to obtain sufficient skills in one area before moving on. The main reason for the departmental review was to address the backlog of specimens. The change in 2019 to move the Campbell River work to another site had been touted as one of the main obstacles to productivity. But by mid-November, when we started the review and the Campbell River work had been off-site for a month, there really was no substantial forward movement in productivity. So we could tell that we really needed to assess things and see where things were at. One of the anecdotes, as I'm going to just give this to James for a second to talk about Somagen's involvement, was, of course, when you bring an outside set of eyes in, they're going to see something that you don't see. And so Somagen discovered that people were using a cell phone to take gross pictures for the pathologist, which, I'm glad we found out so that we could address it. But it's one of those things that you hope you don't find.
All right, well, thanks, Janice. Thanks. I just want to take a quick little note here on who Somagen is. We are the Canadian distributor of Sakura for the last 25 years. With that said, my working relationship with Janice started in March of 2019. After she settled into her role as the technical coordinator, my colleague and I made a trip out to Victoria to meet her and better understand her role and her mandate. We had worked with her predecessor on multiple projects in the past, and meeting Janice was a seamless transition. My first impression of her was that she was very strong technically. As we got to know each other, it turns out that both of us did our medical lab training program in the same city of Edmonton, but we went through different programs within the city. So back in those days, my friends may have called me JT to Janice's JZ. But we definitely both gravitated towards AP instantaneously. It became very, very clear right from the start that Janice had prepared herself on the Sakura file, so all the instruments that we had to offer. As Janice and her team were getting their immediate wins during the spring and summer of 2019, we were also engaged in a technical conversation about Sakura's automated embedding system, the AutoTEC A120. And during those first 6 months of working with Janice, she definitely had multiple attributes or pillars of leadership that definitely stood out to me. First and foremost, as she's already mentioned in the presentation earlier, was her vision for the lab. So during the interview process, she had this positive vision of what the lab could be, and she was definitely able to verbalize that to her management team. Her authenticity. So whenever we're in communication, it's always been transparent and direct communication with her team, her staff, and vendors like myself. Her integrity, just the simple fact that she's very clear with her decisions, and they're always there for the benefit of the patient, right? So we always understand that the reason she made that decision was for that purpose there. And obviously she has the influence of her management team. So we knew that she could definitely have a lot of say in that context. And lastly, Janice is a very, very humble person. The words I just used to describe her, you'll never hear her mention those about herself. She's just more concerned about getting the job done and getting it done the right way. So from our end, it was very easy for us to collaborate together. So as part of our collaboration process, Janice invited my colleague Anne and I on site so that we can provide a third-party assessment of their current situation. She was very clear that we were free to observe and talk with all the staff on all benches. Being a vendor of multiple pieces of equipment at the site, we also committed to being as non-biased as possible while offering observations and suggestions throughout the lab. The two of us, Anne and I, have seen our share of observations. I've seen our share of AP labs across the country, and we're excited to work with Janice. We were just as excited actually to leave the -25 or -13 Fahrenheit and multiple feet of snow in Edmonton for a nice visit out to Victoria, which was a nice comfortable 8 degrees Celsius or 46 Fahrenheit with no snow. We ended up spending 2 full working days on site for our assessment, and we could tell that these staff members were not intimidated with change, a very valuable quality to have shortly with a pandemic creeping around the corner. They were used to the concept of change and the positives that can come from it, as seen with Janice's immediate wins. the management team at Island Health, along with Janice, had done a great job in instilling that change attitude with their staff. So I'll just go over some of the observations and recommendations that that Anna and I saw during those 2 days in January. So one of the biggest things that you guys saw in the picture there was just the backlog of specimens at the grossing station. What you saw there were just trolleys full of specimens lined up on the outside, and then inside the rooms were also multiple specimens just waiting to be grossed. Our recommendation there was to have more MLTs or lab assistants trained at grossing specimens, just to keep that flow of blocks through the lab. We also looked at their tissue processors, and sure enough, there was an opportunity to optimize tissue processing. Just like a lot of labs, once a processor gets installed, 10 or 15 years ago, most often than not, folks don't go back to optimize processor maintenance or protocols, because maybe grossing parameters have changed, things have gotten more standardized. So there is always an opportunity to go back and cut down on processing times and so forth. I think Janice mentioned this on her previous slide as well, but we did notice that the observed embedding and microtomy metrics were below their department guidelines. So our recommendation here was perhaps shift away from what they call their pod workflow, and Janice will touch upon that in a couple slides later on, and or incorporate some automation technology so that staff could be reflex to other parts of the lab that had a larger bottleneck. The other observation we noticed was that there was a minimal communication between their day staff and evening staff. Essentially, I think the day staff ended at 3 and the evening staff started at 3:30, and there was, again, minimal crossover there. So we had suggested utilizing their CoPath data and perhaps having a large digital screen up in the lab so that you can see data in real time. Whether that reflects block status, slide status, if there's any stats coming into the lab, frozen sections, or any other important communications that may be required between staff there.
Yeah, so some of the combined observations that we saw were that staff had a relaxed attitude towards the work. So again, just putting out some clear expectations regarding performance. There were multiple ongoing disruptions in the department, and so we needed to discover a way to reroute phone calls to the call center. There were some just technical issues, so at grossing and embedding and cutting, tissue being too large, reprocessing bubbles. So this was a good opportunity to review some of our grossing protocols with the PAs, review embedding procedures, and find ways to document the issues better in CoPath so that we had a more concrete idea of what issues are occurring so that they could be handled technically. And then something that Somagen put forward was there was no specimen tracking from between the gross room and embedding. So was there a way that we could track this through CoPath or a third-party system? So these combined observations we presented in early March to the leadership team, the medical lead, the site chief, the unit coordinator, and my operations director. All 5 of us were sitting in a conference room in March of 2020, and little did we know that even this small act was going to change within a few short weeks. This first meeting started a process of meetings to discuss and follow up on the items identified in the assessment. One such item was the one item identified by Somagen was to track blocks from the moment they were created in the grossing room. And so this began like a small side project where we built a tracking system in CoPath, which is the software that we use in our lab. And this was exciting for us because it was something that we wanted to do, but as one of those like small side projects, you never get the go ahead to do it. So we built the tracking system and we trialed it. Unfortunately, there were some unforeseen issues that just created a bunch more work for our grocers. And so we weren't able to implement it in the manner we had hoped to. But yeah, it was one of those things that a project allows you to try new things. In early March, we were seeing the rest of the world deal with an outbreak, but it hadn't yet been called a pandemic. In fact, in February of 2020, I was preparing for a trip to Nigeria, and so was actually more concerned about getting my yellow fever vaccination than COVID itself. We continued with our change initiatives. We went live with the DACO Omnis immunohistochemistry platform. We started building the business case for the Autotech A120 to aid in our staff shortage and bring some automation to our workload. The A120 has a potential to be a big win as it embeds 120 blocks per hour, which is more than any experienced staff member. And as we know, training new staff takes time, and so the A120 would be a big win in that regard. It also would be one of the combined assessment comments had been to review grossing practices and embedding practices, and so the A120 would allow us to do that as we trained pathology assistants to gross differently for the A120 itself. And it would also change the embedding practices for the remainder of the specimens that we had left to embed manually. So March 11th, the World Health Organization officially declared COVID-19 as a pandemic, and Canada crossed the threshold of 100 COVID-19 cases. Major sports were such as the NBA and the NHL suspended their seasons. On this day as well, Harvey Weinstein was sentenced to 23 years in prison. And on a personal note, I celebrated my 40th birthday. It's interesting to me to see that we crossed the threshold of 100 cases as at the beginning of the pandemic, because as of August 17th, so just 2 days ago, our active cases in British Columbia was 5,296. So the difference that a year and a half makes in that. So yeah, by the end of March 2020, we were, British Columbia was in a lockdown. So we had just presented the final review of data from both Somagen and our in-house reviews, and we're preparing for the next steps of implementation and trialing changes when we were mandated to a lockdown. For me, that meant transitioning from working on site to working from home. In the beginning of working from home, we were given remote access, but our server capacity could not handle the amount of people requiring remote access. So that was a fun first few weeks. And just even on a personal note, working from home for me also meant my husband was working from home, and my son at that time was completing grade 7 from home. So there were moments of all of us juggling phone calls and Zoom calls and chat rooms, and not trying to be too loud for each other, but then also trying to curb the dog barking at the mailman. So yeah, there was a quick learning curve to figuring out how to manage projects, implement and track changes when I wasn't physically there to support the department. So yeah, this would be the first of many changes that happened. I'm a very hands-on manager, and the pandemic really took that away from me. I hope that the departments don't feel that I micromanage, but I think I do best when I'm in the middle of it, and when I can see the instrument or the error or the person. It really helps me understand the issue and gives me a better way to communicate the changes and expectations to the people on the other side of it. But here I was, mandated to work from home, conduct virtual meetings, and send memos. In a physical sense, I went from an office with dual monitors, a printer, and my files to my kitchen table, my laptop, and what files I'd been able to grab as I left the office. I literally left work on Wednesday and started working at home on Thursday. April 2020, just because I was working from home didn't mean that work stopped. So we continued with the implementation of the changes that we had already started. So this meant looking at our skin protocols, including our melanoma sentinel node protocol, our breast protocols. At this time, we still had equipment arriving, so the SynPrep 5000 arrived in April of 2020, but actually was unable to be installed due to travel restrictions and the lockdown. Every day was a new challenge as we received new information from the Royal College of Physicians and the British Columbia Centre for Disease. This information had to be read, cross-referenced with our protocols and procedures, memos sent to outline updates or reassure staff that the current safety practices met the requirements for COVID-19. Weekly lab management meetings were set up to discuss the impacts, regulations, requirements across all the departments. This included even setting up testing for autopsies to ensure that the patients were COVID-19 negative prior to proceeding. And then this also led to the OR closures. Only essential surgeries were being completed as the hospitals prepared for a surge in COVID-19 patients. By June of 2020, there had been a significant OR closure and the wait lists were just getting longer and longer. Surgeries were no longer something to be put off, so work began on what was then called the COVID Ramp-Up Project. The government's aim was to attempt catch-up on all the lost surgeries from the OR closures by the end of the fiscal year. This meant for the ORs, nurses, anesthetists, lab, everything had to be looked at to ensure that this could be supported. The government also funded new equipment and personnel to ensure that this could be supported. And just as with all things COVID, even the name of this project quickly changed from the COVID Ramp-Up Project to the Surgical Expansion Project. Essentially, the increase in ORs and procedures was here to stay. This would be our new normal. Based on the expected surgical increases across the geographies in Island Health, the AP department was given a short window of time to identify how this would impact staff and the departments. Essentially, I had to determine from a list that was given to me how many more surgeries and specimens we would be receiving, how much more work this would create for the techs based on the specimen type. And then from there, we put forward how much staff we would need to meet the demands and what equipment would be needed to meet this as well, so that the departments could be fully functional. This led to an inventory check of our instruments, of the ages and capacity of our current equipment. And so we put a list forward of what was needed to support this surgical expansion project. Some of the instrumentation identified at this point, and also like from our review process, was processors. We were already at capacity. Our H&E stainers were aging. We were maxed out at microtomes, and some of our embedding stations were also aging and unreliable. This was the beginning of July, and so that meant we had 8 months to put this together, to order instruments, install instruments, have them invoiced by the end of the fiscal year. As I'm sure most of you are aware, it's a big feat to purchase one processor in a year for one site, let alone to do this for 4 different sites. So this took a lot of planning and communication to put together, and it took pretty much the rest of the year to pull this off. Based on our business plan and our review, the first instrument to arrive was the Autotech A120. And due to travel and COVID-19 restrictions, it made a challenging environment to do training, instrument validation, and go live. the A120 was identified as essential to aiding in the workload and technical shortage. Apart from ensuring the instrument did its jobs, we also had to train our pathology assistants to produce sections appropriate to the A120 requirements. As James mentioned, the pod usage in Victoria, which is why there's a pod of peas on the screen, was changed with the introduction of the auto TEC. It did change the workflow in the department and the approach to embedding. Previously, the department had implemented the pods, so essentially all skin blocks were embedded by one person and cut by two other people, and then the same for small biopsies and the same for large resection blocks. Within the pod, the cutters would cut what was embedded for them. So again, techs would only cut skins or only cut small biopsies or only cut large resection cases. The auto TEC changed that in allowing the work to be reallocated as well as staffing to be reallocated. So while there may physically still be pods within the department, staff now cut whatever blocks are ready, and staff have really responded to this change in a positive manner. One of the big shifts in the use of the A120 is the push of the embedding orientation work to the growth room and the pathology assistants. This meant that the growthers needed to be much more cognizant of the section, how it was put in the cassette, was the section thickness. There was a lot of work being pushed to the growth room, and so to ensure that I got buy-in from the PAs, we actually brought one of our PAs with us to the site visit in Michigan, so that for the training learning stage, we could have a PA who encouraged the adoption of the system. James, back to you.
Okay, thank you, Janice. So in the summer of 2020, we recollected ourselves after a life-altering spring there. Although cases were down throughout Canada, all the businesses had a new reality to adapt to. For Somagen, this meant that any travel had to be deemed essential and approved by our senior management team. As you can see on the slide there, these are snippets from the year 2020 in August, where Alberta is the province from where I'm from. We had a whopping 121 cases back then, and in Canada, in August, we had about 126,000 cases. We fast forward to 2021, and as recently as 2 days ago, Alberta was getting case counts of over 400. So it's definitely a different world that we live in now. So as I mentioned, things were changing in 2020. This definitely affected how we were going to do on-site training for the staff at Janice's site. We had to be extra organized due to COVID-19. As only essential staff could go. This meant essentially that every minute that my application person, which would be Anne DeWolf, was on site was planned for. Normally we would have probably 2 folks there to onboard people, but one was deemed essential. Janice's plan was very, very ambitious. We wanted to get things done in 4 weeks, so this meant training the PAs, training the techs, training the pathologists, and having all the slides validated. With that said, we put our heads together and we collaborated on a plan. The idea here was to start off with a single tissue type, and we presented that to Janice, and she chose the appropriate tissue that she felt her staff would respond to the most and have the least learning curve. As you know, she does know her staff the best. So once we had that collaborative plan in place, we were shipping off and hoping for success there in 4 weeks' time. So during that 1 month long process, Anne and Janice definitely had many frequent transparent progress reports, just so everyone was up to date on what was happening, what was the goal for today, or what was the goal for this hour, just so things were being moved along, and if anything got left behind, it was quickly picked up and followed up upon. So for example, Janice and Anne worked together on the staff scheduling, following up with the pathologist once the slides were ready for review, and then identifying any knowledge or technical gaps that required any follow-up. And obviously the last part there, communication was paramount during this phase, definitely between Anne and Janice, both of them being present at the moment, having those active listening skills, being open-minded for alternatives, and looking for feedback. Right, it's not about criticism; it's about feedback, and having trust in that process and respect for each other. So I know that those were the comments I got back from Anne for this presentation about Janice. So again, some of those important communication skills were paramount during this process. So in terms of instrument training, or what we call paraform training, because those are some of the specialty cassettes for the A120, and worked one-on-one with the grocers there, and dedicated a couple hours for each one, and would rotate between grocers so that each of them would get a section of her time per day. Just because everyone does gross differently, there are different habits. We wanted to respect that and make sure there was quality training for each person, and that they felt like their concerns were properly addressed as we were going through this process, because it can be quite intimidating for a grocer used to cut tissues into cassettes, and now we're asking them to make it a little bit smaller, a little bit this, a little bit that, right? So it definitely impacts your day-to-day routine. So we definitely wanted to respect what changes that they were about to go through. The next thing was working with the lab assistant or the lab techs who were in charge of taking the Auto-to-EC magazines out of the tissue processors and loading it onto the instrument itself, as well as training staff on how to operate the system from a day-to-day operation standpoint, as well as maintenance. So again, Anne spent dedicated time with staff members there, going through different scenarios on how to work with the system there. And then probably one of the most important things is working with the techs on microtomy as well. I used to be a cutter too, and I remember I had my station set up in a specific way. So cutting a block can be very personal. So again, we went for that one-on-one training moment there with the techs, and would sit down with them and then kind of show them how this is done, and then work with them for the individual nuances, if you will, just so we can get a nice section coming off of like a paraform block. And then the last two steps are essentially just staining the slides on the H&E stainer, special stainer, and IHC stainer, and then presenting it to the pathologist. And on the last point there, it's probably just making sure that the pathologist has the time to look at it. So whether that's Anne or Janice kindly knocking on the door as a reminder to, hey, can you take a peek at this? Just to, again, to move the project along. But everything was done in 4 weeks, and it was a nice accomplishment for the team over there. Oh, right, sorry, I forgot about this little guy here. So I was gonna say, guess who went through each step? It definitely was Janice. She went through it, just like as she mentioned, she likes to be in the thick of it. She was definitely leading by example. So whenever there were any technical issues, she can definitely be in the right headspace about, oh yes, I know exactly what you're talking about. Let's work out this together and work with our staff to get additional buy-in and lead through that type of example. So in my opinion, the changes that Janice brought and will bring to the lab is a result of her leadership qualities and exceptional communication skills. As a vendor ourselves, we're often the ones who are providing valuable information, but I believe in this case, so the Somagen team felt like we got a nice reminder of some of these important leadership qualities and communication skills. So without a doubt, without Janice being there to lead this project, we wouldn't have gone through the change process with her. So back to you, Janice.
So yeah, this is a very accurate picture in what the last year has felt like, and I think James can attest to that fact, that he has seen me with my hands full in the last couple of weeks. Some of the other changes that we brought to the lab were 2 new Polaris processors. The thought with these was to meet the need today, to increase capacity for processing, but also to plan for future growth in the department. The Polaris allows us to use the same footprint in our department as our previous processor, with the same amount of reagents, but with dual retorts, so we can process twice as much tissue. Again, as we move forward in optimizing and new strategies. We're going to look to rapid processing and other cycles on this instrumentation. Shortly after the Polaris arrived, we also brought in new H&E stainers, again looking to the immediate needs and future planning. We were replacing very old stainers with new technology, and for one site in particular, that meant that we could finally have a single flow workstation where the cover slipper and the stainer were joined. As well, for that site, it provided the opportunity to bring some automation to the department in the way of adding their high volume special stains to the instrument. In labs where space is always a premium, it was important to find instruments that could meet our need, but also fit in the department. Other notables for this year, Somagen had identified tracking in the growth room, so we did in fact trial this with our current CoPath software, but the task was cumbersome and required a lot of clicking and moving between screens. So that's back to the drawing table for now. Obviously, with the use of cell phones to take pictures, cameras are also identified as a needed asset. So that has been put on our capital list, but we did implement a new image identification process and create a secure server for our growth room images. We're actually still going through some upgrades to our dictation system, which has required several Zoom training sessions and email memos and communications to identify site super users and training dates. So lots of new technology being employed in the labs. And one of our sites, Nanaimo, also had to go through some staff and scheduling changes to accommodate the workflow that changed with the Campbell River site and the new equipment. Again, at some point or another, all of these projects were impacted by site closures and outbreaks at facilities. That meant I couldn't travel or couldn't be on site. Not to mention the rolling provincial lockdowns that would happen as the COVID-19 numbers fluctuated. And the impact that we never saw coming was the backordering of supplies and the impact to the plastic world. I had to learn quickly to reach out to my provincial and research partners to secure supplies. I wear multiple hats, and so one of those hats is that I actually sit on a council called the Nursing and Allied Health Advisory Council. This was established back in 2019, and the aim was to provide a space similar to NAHAC, where policies and protocols and processes can be brought forward for review and advice on how they may impact the work of nursing and allied health workers. As the name implies, it consists of nurses and X-ray, ultrasound, social workers, spiritual care, food service employees, housekeepers. The aim of this council is to include a representative from every area so that there could be increased awareness of how protocols, policies, processes affect every area. The goal being that deficiencies could be identified and rectified prior to implementation. Obviously, this was started in June of 2019. That was when we first had our first meeting, but little did we know how important this council would be in the face of the pandemic. So yeah, with the speed of changes that COVID caused, these meetings that began as one every 2 months were quickly ramped up to a meeting every 2 weeks, so that timely advice could be provided to those seeking it. We recently had a NAHAC COVID debrief in one of our last meetings, and they asked us to provide feedback on two fronts. The first being what were the positive outcomes from the pandemic, and the second, what had we learned from the pandemic and what could we do better? There was a lot of important work done, and new objectives were realized through COVID. As the usual timeline restrictions were removed, projects could move forward more quickly. One such project was the Hospital at Home project, where patients were released to convalesce at home, but with regular nursing visits, this meant that beds were available at the hospital. And so that was a big win in the face of the pandemic. There was also the recognition that some decisions were made where we haven't seen the outcome yet, or perhaps even what kind of damage may have occurred through the restriction of visitors or caretakers during COVID. Did we silence the voice of those who needed someone to advocate for them? We may not know the adverse effects of these decisions for years or months, but yeah, it was trying times, and for many of the people, positions represented on the council, it was important to make these discoveries on the good, the bad, and the ugly. One last hat that I wear is that I work as an eye retrieval technician for the Eye Bank of British Columbia, and this area as well faced many challenges, as there was much unknown about COVID-19 in the beginning, and what effects the virus would have on tissue, on donated tissue, as well with the lockdowns and the restriction of staff in hospitals. We weren't sure what kind of access we could have as a contracted employee. We're not tracked when we're on site doing retrievals, and so there was concern that if there was a outbreak on a ward, how would we be contacted or notified regarding quarantine or isolation? So yeah, even now as the restrictions lift, there's still, we look for evidence of a negative COVID test before proceeding with an eye retrieval. Pause. Growing up, my family moved a lot. We never stayed in one place for more than 5 years. As a child, that was very challenging, but I attribute my adaptability as an adult to it. In the last 18 months, I've learned to be a better communicator with not being on site or not being face-to-face. That meant I had to learn to communicate more clearly via the phone or email, which can be difficult when tone or facial expressions aren't seen. To listen more closely, to employ active listening. I've had to learn new skills quickly, negotiating, crunching numbers. I didn't realize that my job was part accountant, part negotiator. I've also learned that I quite like project management, but the chaos that project management has brought means that perhaps procedures have slipped. I've also realized that I didn't approach the department review without my own biases, that instead of letting the job and work speak for itself, I inferred my own thoughts as to what the causes of the issues were. And well, perhaps they may have been somewhat legitimate. They may have clouded the process, and what could have been better outcomes were lost. So I'm learning to ask better questions because I do not have all the answers. Change. I love this image because change often feels like it goes by at a snail's pace. But in the last year, it has gone at a turbocharged pace. And so, yeah, the experience has been full steam ahead. Usually equipment that sits on a capital list for 5 years or more was quickly approved and had to be purchased within a short period of time. We're still experiencing growing pains. Having our new equipment arrive so quickly, so close together, causes some growing pains and some challenges as we optimize and validate. It feels like that's all we're doing lately. So yeah, change that would happen in a normal world over maybe 3 to 5 years, each site on its own, has happened in a mere 10 months. Like I said, there have been growing pains. To say the last year and a half has been a breeze would be to underestimate the change process. We've had many growing pains in the implementation of our new processes and policies and procedures and equipment, and we still face growing pains and optimization of the equipment. James can testify. He had to be on site last week, and he can testify to some of the issues that we were working through last week. So I appreciate his curiosity and his ability and help to think through some of the troubleshooting aspects that we were facing, and the time he took to communicate with us in the department. This year has brought a lot of change in unprecedented circumstances. When I started working in healthcare, I can honestly say I never expected or was prepared to navigate a pandemic. This year brought challenges, new opportunities that arrived at breakneck speed. It's required us as healthcare workers to be flexible, which may not be a trait that we are well known for. There have been great opportunities to move healthcare forward. Initiatives that previously took years have been approved and implemented within months. On the flip side, there are still opportunities to learn and grow from this experience, things that were not done well or things that could have been done differently. My personal philosophy has always been to accept change, to lean into it, to see what the future holds. And I hope that as I walk this out, I will be an advocate for change that is done well. Thank you.